much, no? I mean, simply it's not necessary. Keep in mind that the length of the thread on the implants is 5.5 millimeters. So anyway, if all those 5.5 are inside the nose it is going to be there's no support. Okay, fourth discipline, engagement in the pterygoid plate of the sphenoid bone. There were a lot of speakers talking about this. So this bone, this red bone, denominated with A, that's what I'm talking about. This is the pterygoid process, and you can insert one or two implants there. There are a lot of anatomic variants regarding the position of the sphenoid bone and the distal maxilla. So sometimes the sphenoid bone is shorter, as shown on the left side. Sometimes the sphenoid bone peaks a little bit out, in case B, atrophy of the maxilla, and there are some cases with extreme atrophy of the maxilla. There you can really see, not only palpate, but see how the sphenoid bone, how this pterygoid process bulbs out the mucosa. So there are a lot of options. I think today this double tuber pterygoid placement is state of the art. Most of us are doing this. I don't see too much triple tuber pterygoid, but that's possible, of course. Keep in mind, if you look at these pictures, there's always a fissure, a lower fissure between the maxilla and the sphenoid bone, and there's also an upper fissure between the maxilla and the sphenoid bone. So the implants should reach this target bone between the two fissures. So if you are cranially to the upper fissure, there's always a danger of injuring the palatal artery. I mean, the real danger zones, the maxillary artery, for example, this is far away. I mean, it's very difficult to hit there. You need a real long implant, 4 centimeter or more. But still, even if you hit the palatal artery in this upper fissure, it can lead to bleedings and complications. So try to stay always between the fissures, or as shown in picture C, you can also engage only into the pterygoid plate of the sphenoid bone. This is a 3D model. The 3D model from the other side. Here you see the sphenoid bone. You also see the small black opening which represents the palatal artery. If this artery gets injured inside this bony canal, there's no problem, and there's not enough pressure on this artery to cause a severe bleeding. But if you should injure this artery outside, very often you have to do something to close it or to compress it. There are two muscles being attached to the sphenoid bone, to the pterygoid process, and these muscles are giving the stability to this bone, and they cause the high mineralization, and this mineralization remains even after the teeth are extracted. I mean, these muscles are activated also by mouth opening, mouth closing. So other than the alveolar bone, which goes with the teeth, the sphenoid bone is very, very stable. Yesterday, a colleague after lunch mentioned look out for the white lines. This is a very good recommendation, and I like this a lot. So you can see also in the area of the sphenoid bone white lines, and these are the target zones for the threads of the strategic implant. Well, this picture is for me always very impressive. As you can see, the distal maxilla provides bone of very low mineralization. I mean, it's a D4 bone, and I mean, this is from the sphenoid bone, which is on the right side, right away to let's say the area 3 or 4. And what I always find amusing, I mean nowadays amusing, how the professionals, I mean the big profession of dental implantologists, how they spend, I mean, years and lives and efforts to deal with these bad bone zones. I mean, sinus lifts and whatever. If the good bone is only 1 millimeter away, you know, I think this is completely stupid, and it's completely, you know, it shouldn't be done anymore, because every patient has the good bone. The good bone is reliable, and I see no point to do a sinus lift nowadays. So even if the patient has a has a missing first molar in the upper jaw. As long as the second molar is there and the premolars are okay, I will always treat this with a bridge. I mean, this